Hey everyone, it's Friday, which means it's time for kind of the weekly compilation video about the topics we've discussed this week. First of all, I wanted to say thank you for all of those that have recently kind of joined my Instagram feed and my Facebook page. I really appreciate you all helping me kind of do this and liking and commenting on the content I produce. It's good to know that people are enjoying what I'm doing. So, I've had a lot of questions this week, and that's really great. So I want to make sure I try and address all of those. But obviously, if you have any additional questions, feel free to reach out and let me know with those. Just as a reminder, I can't necessarily answer, specific patient questions about your specific health. If you have a topic, I'm happy to talk about it in general. But, I can't necessarily give specific advice over the internet. So anyway, this last week we talked about kind of the differences between systemic estrogen, vaginal estrogen. We talked about DHEA, how that can be used for things. And we also talked about kind of using estrogen to treat both recurrent urinary tract infections and recurrent bacterial vaginal infections, especially in people in low estrogen states. So I'm going to kind of combine the estrogen topics together and then talk about DHEA kind of on its own. So the take-home message for this video is, if you are postmenopausal, whether that's you went through menopause on your own, you had your ovaries removed, you had to go through chemotherapy, whatever it may be, if you are a hypoestrogenic individual, you probably should be on some sort of vaginal estrogen. There are very, very, very few contraindications to that. It has almost no systemic spread. You don't have to be on another medication called a progestin if you're just taking vaginal estrogen alone. And study after study after study demonstrates its efficacy in promoting health, long-term health, decreasing the chance for urinary tract infections, bacterial infections. It can also help with things obviously like vaginal dryness and painful intercourse and things along those lines. So that's a take-home message. And the second thing is, if you can take vaginal estrogen, you can most likely take vaginal DHEA. And by that, you can obviously get that compounded, but I really mean specifically for this, the FDA-approved form of that, which is a medication called Intrarosa. And I'll talk about that in detail too. So now, systemic estrogen therapy, if you look at the recommendations from the North American Menopause Society, there are basically four main indications for hormone therapy. And these are in patients that are menopausal, perimenopausal, and in women or individuals that go through menopause under the age of 40. So the first indication is for the treatment of vasomotor symptoms. That's like hot flashes, night sweats, things along those lines. The second is for the treatment of genitourinary syndrome of menopause, which we talked about a lot this week. That's kind of all of the vaginal and vulvar symptoms of menopause. So vaginal dryness, painful intercourse, atrophy, which is kind of shrinking of the tissue, and then the urinary and vaginal infections. The third is for either the treatment or prevention of osteoporosis or brittle bone disease. I'll probably talk about that sometime in the future. And then there's a specific indication for individuals that go through menopause under the age of 40. Because if you go through menopause when you're in your mid-30s and you don't do anything, you have a much, much, much higher likelihood of having things like heart disease, dementia, Alzheimer's, all sorts of other bad stuff that you don't want. So if you are in that category and your gynecologist or primary care physician or whoever is not prescribing you systemic estrogen, find someone who will, because there's data that says you need it. So anyway, so for systemic estradiol therapy, the preferred means is via a transdermal route. So either like a patch or cream, they make a little mist called an Ava mist. And the rationale behind that is because that transdermal application of estradiol decreases or has a lower likelihood of causing some sort of venous thromboembolism, so like a blood clot, and things are related to that, so like stroke, heart attack, stuff along those lines. Remember that all sex hormones, so estrogens, progestogens, androgens, are derived from cholesterol. This is why people who are very, very, very skinny typically go through puberty at a later age, or people who are very active, like if you have let's say a teenager, teenage girl who is doing track and gymnastics and all this stuff, and she has a BMI of, like 14 or something, the likelihood of her going through puberty or having kind of normal menstruation is very low because she doesn't have that extra cholesterol in order to synthesize into the sex hormones. So if you were to take an oral estrogen, that goes and gets broken down by your liver. And one of the things your liver does is it dissolves it into its base components, which is cholesterol. And if you have an increase in cholesterol, as most of us know, you're at a higher risk for heart disease, stroke, blood clots. Ergo, oral estrogens are associated with a higher risk of those issues. Now, there is some stuff with inflammation in there too, but that's the best way to think about it. It's a cholesterol thing, you know? So the transdermal applications of this hormone avoid that what's called hepatic first pass metabolism, or that liver breakdown into cholesterol, and so you don't see that same rise in those venous thromboembolisms or those, you know, blood clotting issues. Now, if you are on a systemic estradiol and you have a uterus, you need to have some sort of progestin in order to prevent the development of what's called endometrial hyperplasia or endometrial cancer. Endometrial hyperplasia is can be a precursor to endometrial cancer. And the reason is because that estrogen will cause the lining of the uterus to fluff up and fluff up and fluff up. And if it gets too fluffy, not only do you have bleeding and other things like that, but the way that kind of cancer occurs is, you know, all cells have a programmed what's called cell death. It's called apoptosis. And they have like a timeline, and they say, okay, it's been 24 hours, cell. Now it's time for you to die. And cancer cells are like, heck no, yo, I got time left to live. And they just keep staying around and they keep reproducing incorrectly, and then they get out of hand, and then you get cancer. So that's what happens when you have all of this kind of cellular turnover there in that endometrium with the unopposed estrogen. So the progestin goes in basically and solidifies it and pulls it back down and says, nope, you can't grow with that. So if you are on a systemic estradiol, you need to be on some form of progesterone, whether that's a oral progesterone or a transvaginal. Now, transdermal progesterone, and we see this a lot of times in certain compounded things, doesn't have the same type of absorption that oral or transvaginal progesterone does. Progesterone is much better absorbed through mucous membranes. The what's called lipid bilayer, or kind of fatty layer in our skin, makes it a little bit more difficult for progesterone to really absorb through there. So you may not have the same benefit, you know, if you're taking using like a progesterone cream or something along those lines. So the benefit, once again, for doing the transdermal is like I said, decreased chance for stroke, blood clots, all those things. The other benefit is that it's going to help with things like hot flashes, night sweats, and it's also going to help with things like with your bones, you know, to make sure that you don't have osteoporosis or decrease the likelihood of that. Now, a question I often get asked is, if I'm on a systemic estrogen, do I need to have a vaginal estrogen as well? And that's kind of an individualized thing. Obviously, there are estrogen receptors within the vagina, within the vulva, and if you're on a systemic estrogen preparation, those receptors are going to get plugged, and so you are going to get some effect from it. That said, genital urinary syndrome menopause, or GSM, which is the big deal thing that's causing all those changes, especially in severe forms, some people do need vaginal estrogen as well. Now remember, you're not going to overload those receptors and have too much estrogen in there. If we draw estradiol levels throughout a normal menstrual cycle, we'll see numbers from the low 20s to the mid 300s. So I mean, you know, and this is why you don't even really have to test estrogen for hormone therapy, because, you know, let's say we test your blood and it's a 42. The next time we test it, it's a 100, whoop-de-doo. It doesn't mean anything because there's so much variation in a normal cycle there. So you can't have too much vaginal estrogen, you know, with some very obvious, very specific exceptions. The other thing that we see with estrogen, especially systemically, is that it's going to help with cognition. It's going to help with things like brain fog, forgetfulness, and some of the mood stuff that a lot of menopausal individuals have to deal with. Vaginal estrogen specifically, you don't have that systemic spread. It's just in the vaginal tissue, and it gets to the vulva as well. I had a person ask me about that, and to the vestibule. So that whole kind of vaginal lower genital tract is going to get those receptors plugged with that vaginal preparation. And remember that the vagina and the vulva are very high in estrogen receptors. The vestibule, and I've talked about this before, is high in estrogen, and androgen receptors. And that's why testosterone is often used for patients who have vestibulitis, because it goes in and helps plug that. And that's why DHEA, which breaks down into estrogens and androgens like testosterone, is really helpful for patients that have a lot of vestibular dysfunction. So anyway, there's that. There's a bunch of different types of preparations for vaginal estrogens. There's vaginal creams, vaginal tablets, vaginal suppositories. There's two vaginal rings. One just gives a local kind of application. It's called an S-ring. And then there's also another medication called a FEM ring, which is a vaginal ring, but it also gives systemic estrogen. These are really nice because you only have to change them every 3 months. You put it in, 3 months goes by, take it out, put another one in, bada bing, no messy cream, no tablet, no anything. You don't have to worry about it any other time. It's just there. You can take it out when you have sex if you want. You don't have to. It's kind of up to you, but those work beautifully. So let's see, what else with that? The urinary issues. Now remember, in the urinary kind of video, we talked about what's going on as an architectural change within the vulva, within the vestibule, within the vagina. There's a change in the receptors, so that tissue that normally was very rich in estrogen becomes depleted, and it becomes very irritated and aggravated, and very tender to touch. Now, the tissue around the urethra starts to thin out, and like I said before, that urethra can actually roll forward to make it into more of a position to where bacteria from sexual contact, from E. coli coming out of the colon, whatever it may be, can come in and kind of invade that and lead to urinary tract infections. So now in the vagina itself, remember there's those two cell types. There's our parabasilar cells, there's our superficial cells, kind of vice versa actually. Parabasilar cells are the scaffolding of the vagina. They're what hold things in place. They don't stretch, they don't accommodate. They're like, this is the shape, this is what we got. The superficial cells go and line those parabasilar cells, and they are there in much, much, much higher amount, and they allow that tissue to stretch, they allow it to accommodate. I mean, if you think about it, a baby can come out of a vagina. Like, that's crazy. I mean, I don't know, you've seen kids and you're like, oh, you have a 13-pound child. I mean, I delivered a 13-pound baby vaginally. I didn't personally deliver it from my genitalia, but I helped a woman deliver that baby in an obstetrical standpoint, and she had no tears. Like, think about that. Like, that's amazing. That tissue can stretch so much. But in low estrogen states, all of that stretchability and that pliability goes away. And so you get very, very rigid tissue that can easily tear. It's very uncomfortable. And so that's what that vaginal estrogen does, is it goes in and it replaces those superficial cells, causes them to plump back up, and it allows them to kind of get to that accommodation again. So with vaginal estrogens, you're not going to have a noticeable serum or blood level increase of estrogen. So if someone puts you on vaginal estrogens and they're checking your estrogen levels, not going to see anything, and that's okay. It doesn't mean it's not working, but we're not expecting a blood increase in that. So that's about that for vaginal estrogens, how it kind of helps prevent urinary tract infections. As far as recurrent bacterial infections, what's going on is that the vagina typically is a very acidic environment, secondary to lactic acid that's produced by lactobacillus. Lactobacillus requires a very estrogen-rich environment to live well. And obviously, as that estrogen levels go away, it becomes more hostile for those lactobacilli, and they go away, and they don't produce lactic acid, and so the pH, or the chemical composition, acidity level, actually, the acidity goes down, the pH goes up. It becomes more of an alkaline environment. And when that happens, opportunistic pathogens and yeast and things like that can come in and seed. And so that's why postmenopausal patients, or patients with low estrogen, or people that take antibiotics and kill all the bacteria in their body, including the lactobacillus in their vagina, can have yeast infections, bacterial infections, things like that. So once again, going in, replacing the estrogen there, allows the tissue to thicken back up, makes it more happy for the lactobacilli. They come in, start reproducing lactic acid, pH becomes more acidic, everyone's happy. So DHEA. So DHEA, honestly, if I think about hormones, may be my favorite hormone in terms of women's health. It is a prohormone, meaning it breaks down into things. So the full name is dehydroepiandrosterone. So what that means is it breaks down into a type of androgen, and it breaks down into a type of estrogen. Now the androgen pathway goes through this other thing, androstenedione, and all these other androgen precursors to get to testosterone. Estrogen gets basically formed because some of these testosterone precursors go through what's called aromatization, and they turn into an estrogen. Typically it's estrone, which is the estrogen of menopause, technically. But it has so many applications because vaginal DHEA, once again, you don't really have that systemic spread, but not only are you getting the estrogen component that the tissue needs, but you're also getting the androgens there. And like I said, the vestibule is very, very rich in androgen receptors. So for individuals that have painful intercourse with penetration, especially who are postmenopausal, this can be a game changer because not only are you getting the estrogen to allow the tissue to accommodate and stretch and get lubricated again, but those androgen receptors in the vestibule are getting plugged too. And so they're nice and happy. Now, typically low androgen vestibulitis, you're going to see pain up towards the top of the vestibule around what are called the periurethral glands or the Skene's glands. And this is because embryologically, the vestibule, especially that part, is very close to the area in a male patient of the urethra that comes out of the prostate. They're called a homologue, and it's very androgen sensitive there. So if you are doing a vestibular exam and you go up and you poke kind of in the area by the urethra and the patient says, oh my gosh, that's the worst part, you really need to be thinking about vestibulitis with that, hormonal vestibulitis. DHEA, like I said, precursor hormone. If you can take vaginal estrogen, you can usually do vaginal DHEA. Now, if you take oral DHEA, once again, cholesterol based, there goes your cholesterol, it goes up, and it's just going to go and separate into who knows what. You can't control it. You know, I had someone put a thing saying that DHEA was like the ovary whisperer, and I said, well, it's probably more like a bazooka, because it just slams out into whatever it wants to. It says, I'm going to go to some estrogen, I'm going to go to some testosterone. You can't tell me what to do, body. And it's the same thing for some of the other hormone precursors like pregnenolone, which is another one that I sometimes see given orally. But and so for that reason, I don't do oral DHEA because I want to know if I'm going to give a hormone what it's going to do. I don't want to leave that up to chance where it can cause problems elsewise in the body, because too much systemic testosterone for female individuals is very problematic. Not only does it cause cholesterol to go up, it can cause hair thinning, it can cause increased facial hair, acne, oily skin, hair on the body that's unwanted, and in really high amounts, it can lead to voice changes, it can lead to enlargement of the clitoris. There's just tons and tons of stuff that it can do. So I don't want a bazooka if I'm trying to, it's kind of like a sniper rifle versus a bazooka. I want the sniper rifle. I don't want collateral damage, if you will. So anyway, prasterone or Intrarosa is the only FDA-approved formulation of DHEA. It is currently FDA-approved for the treatment of painful intercourse as a result of genitourinary syndrome of menopause in postmenopausal individuals. That said, I use it off-label a bunch for premenopausal individuals. You can use it postpartum. I've used that too, especially if a patient is not breastfeeding, to help with that. I've used it in patients for hormonal vestibulitis. It's a fantastic medication, and if your healthcare provider doesn't know about it, I could talk about it all day long. So I think it's a fantastic drug for this. So that's pretty much it. Oh, lichen sclerosis, vulvar cancer patients. If you have lichen sclerosis and you are postmenopausal or you're in a low estrogen state, not only should you be doing your steroids like clobetasol or betamethasone or some of the other ones, clobetasol is the one I typically use, definitely consider adding an estradiol or even that vaginal DHEA to the tissue to make sure that that vulvar and vaginal tissue, vagina is not really involved with lichen sclerosis, but the vulva can be kind of more resilient. It's not going to treat the disease, but it may help that tissue heal quicker. Same thing for vulvar cancers. Now, most vulvar cancers are not due to any type of hormonal thing. Usually we see HPV being involved, or it may be due to lichen sclerosis or things along those lines. So once again, check with your oncologist. As long as this is not a hormonal cancer that is estrogen driven, you should be given, or consider doing vaginal estrogens, vaginal DHEA as well, because it can really help with that tissue. And irradiated patients, if you have to have irradiation for vulvar cancers or pelvic cancers at all, is something definitely to consider, on top of that. So, and I'll probably talk about cancer stuff in a later video. So anyway, this has been almost 20 minutes. If you're still with me, thank you so much for bearing with me. I appreciate it. I'm very passionate about this topic, and there's a cohort of us sexual medicine providers that are very passionate about this as well. So Rachel Rubin, Joe Kraft, myself, Nisha McKenzie and the WH Collective, Becky Lynn at Avora Women's Health up in St. Louis, and Jessica Bell, she's a Urogyne PA up in the kind of Portland area. So there's a lot of us that do this. So find a NAMS provider, find an ISWISH provider if you don't know what these are. NAMS is menopause.org. ISWISH is International Society for the Study of Women's Sexual Health. That's ISSWSH.org. So anyway, thank you again for watching. Send me questions if you got it. I'm Corey Babb. Have a wonderful day.